Hi everyone, my name is Philip Bouleh. I'm a PhD student in the clinical psychology program at Oregon Health and Science University. I'm part of the social neuroscience and psychotherapy lab, where I'm mentored by Dr. Chris Stauffer in our research on various psychedelic assisted therapies. Today, I'll be sharing preliminary findings from a pilot study revealing how a group format of MDMA-assisted therapy impacts interpersonal traits in a sample of veterans with PTSD. And the title of my presentation is The Interpersonal Dimension of Healing in PTSD, Attachment Security and Epistemic Trust in MDMA-Assisted Group Therapy. So a little background about me and my connection to the topic. Part of what inspires my research in psychedelics and PTSD is my personal ethnic background and the ways that I've grieved to see war and geopolitical conflict affect my people and the region that I'm connected to. I'm Palestinian, Iraqi, and Armenian. I was born in Jordan and raised in Lebanon for the first 11 years of my life. And I moved to the US with my mom and sister in the mid 2000s. And after that, we were granted asylum and settled in the US. So I think clearly there are moments in history and in the present when we lose touch with our sense of empathy and compassion for others. And anything that might help us regain insight into our shared humanity and dignity strikes me as a worthwhile pursuit. So, in light of core aspects of my story and journey as an Arab immigrant, I'm hopeful that we can continue to research the risks and benefits of treatments like MDMA-assisted therapy for PTSD. To do so in marginalized populations affected by trauma, like refugees, military personnel, and those recovering from life in conflict-affected settings. So to begin, I want to share a quote that encapsulates key themes in my presentation. The first theme is about how trauma and PTSD can rupture one's sense of self and the related safety and connection felt within one's social environment. And the second theme is about the unique benefits of communal connection and group therapeutic work for those who experience traumatic stress. So Judith Herman, a psychiatrist, New York Times bestselling author, and a pioneer in how we think about and treat PTSD, said it best in her book, Trauma and Recovery. The quote reads, "Traumatic events destroy the sustaining bonds between individual and community. Those who have survived learn that their sense of self, of worth, of humanity depends upon a feeling of connection with others. The solidarity of a group provides the strongest protection against terror and despair, and the strongest antidote to the traumatic experience. Trauma shames and stigmatizes. The group bears witness and affirms. Trauma dehumanizes the victim. The group restores her humanity." So, diving in here, let's begin by defining some basic terms. So, PTSD is caused by a traumatic event that in turn leads to four clusters of symptoms known as the re-experiencing symptoms, so things like nightmares, avoidance of trauma reminders, developing negative changes in beliefs and emotions due to the trauma, and hyperarousal, like sleep disruption and hypervigilance. Now, one important area that's well established in the literature is the high prevalence of social impairments in PTSD populations. Across veterans and civilians, PTSD is consistently related to poor global social functioning, and this relationship holds across trauma experiences, from various forms of abuse to combat exposure. Now, when we look at studies in veterans more specifically, we find lots of these examples. So in a large meta-analysis, military trauma was uniquely related to problematic anger, which has been shown to be associated with interpersonal conflict among those with PTSD. Then in a smaller study, over 1/4 of female military sexual trauma survivors also met criteria for social anxiety disorder, and they reported less involvement in their romantic relationships and had a harder time with self-disclosure to friends and family members. While various reasons underlie social impairments in veterans with PTSD, one important factor to consider is the effects of adverse childhood experiences in this population, also called ACEs, and they include things like abuse, neglect. In fact, in one study, 83% of veterans reported at least one childhood trauma, whereas 41% reported four or more ACEs. And ACEs have been shown to be related to a lower likelihood of having a good social network in veterans. So given everything discussed here, there's a great need to address the social impairments that we see in this population while accounting for the negative impact of early childhood trauma on social functioning. So now we might ask, why is interpersonal functioning so central to PTSD? So referring to adult onset trauma, several theories strongly emphasize the role of interpersonal factors in bridging the pathway between trauma exposure on one hand, and then the development and maintenance of PTSD on the other. These mediating interpersonal factors include things like poor quality of relationships, limited disclosure and acknowledgement of trauma, and limited social support. In fact, in one study with over 800 adult trauma-exposed patients in the US, 45% reported social impairments up to 6 or 12 months after the trauma. And most importantly, the presence of social impairment contributed to a 16 times higher likelihood of developing PTSD. Now, it's complicated because not only can social impairments increase the risk for PTSD, but the reverse is also true in the sense that PTSD symptoms can also erode social functioning, given the nature of the symptoms. So the takeaway here is that interpersonal factors play a crucial role in the development and maintenance of PTSD, whether the social impairments follow from trauma exposure or if they're maintained by PTSD symptoms. But despite the maintaining role of social impairments in PTSD, the effects of many existing PTSD treatments on interpersonal functioning are largely unknown. So now you might be wondering, how do we practically intervene to improve interpersonal functioning? Well, one approach is to travel far into the past to understand the origins of interpersonal dynamics, whether so during childhood, our experiences with caregivers, whether nurturing or traumatic, they help shape how our interpersonal traits develop in two key domains: attachment security and epistemic trust. They're referred to as traits because they describe stable behavior over time and provide insight into adaptive versus maladaptive ways that adults navigate their relationships. So broadly, these traits help describe how well we're able to learn from others. That's epistemic trust, which is a part of the epistemic stance. And then what kind of beliefs we've internalized from caregivers about our lovability and the dependability of others. That's attachment security. So let's define these constructs. So people who are more avoidantly attached are afraid of intimacy. They have a hard time self-disclosing and they're hyper-independent. Whereas people who are more anxiously attached tend to fear rejection, over-depend on others, and become easily distressed when others are unresponsive. If someone's high on attachment avoidance and or anxiety, they have an insecure attachment. And the more we anticipate them to run into social problems that increase risk for PTSD while interfering with recovery. For example, attachment insecurity is associated with things like poor self-esteem and the use of maladaptive emotion regulation strategies, which worsen PTSD severity. Now, early caregiver relationships also influence the development of something we call epistemic trust. And epistemic trust here simply means trust and communicated knowledge. It's important because if we can flexibly learn from others, our ability to grasp and implement knowledge with appropriate vigilance becomes a source of psychological resilience during crisis. But epistemic trust can also be compromised if our early attachment relationships are a source of harm or neglect. So when we refer to someone's epistemic stance, we're describing traits of varying degrees of openness and vigilance to learning from others. And it breaks down into three distinct factors: epistemic trust, mistrust, and credulity. So mistrust and credulity are the more maladaptive stances of the three. And mistrust involves hypervigilance to the information conveyed by others, where you suspect people have ulterior motives and you're closed off to learning. But then in contrast, credulity is kind of the other extreme. It involves excessive naivety in accepting information, leading to high vulnerability to misinformation and being exploited by others. So high levels of epistemic mistrust and credulity are thought to be maladaptive and increasing the risk for PTSD by diminishing social learning. Now, typically it's hard to intervene in the patient's environment. We can't always control how much access someone has to social support, but if we can perhaps modify their traits, we might not only enhance social functioning, we might actually boost treatment response too by deepening trust and connection, even in therapy. So now I'm going to explain why combining psychedelics plus psychotherapy, specifically MDMA-assisted therapy, why that's well suited for initiating adaptive changes in these interpersonal traits. So first, MDMA-assisted therapy is an evidence-based treatment that's been studied for the last 20 years. It combines MDMA with psychotherapy, MDMA being a stimulant drug that also has psychedelic properties and is well known for its prosocial effects. And based on the available evidence, we know that MDMA-assisted therapy contributed to sizable reductions in PTSD symptoms, as well as improvements in overall social functioning. And this is based on phase 3 data, which showed that 71% no longer met diagnostic criteria for PTSD after the intervention. Part of what sets this treatment apart is the emphasis on relationality as a core tenet built into the treatment manual's philosophy, in the sense that part of what the treatment deems crucial to trauma recovery is the relationship between the participant, their two therapists, and the MDMA, and even the relationship with the broader social environment, such as with family, friends, and romantic partners. In fact, in a recent review, MDMA's prosocial effects were proposed to be treatment mechanisms, and they offered 4 ways that MDMA's effects might modulate social behavior. To offer a few examples, MDMA can modify how one's self-image by increasing self-compassion and bolstering self-esteem. MDMA also can motivate people to socialize with others. So people increasingly report feelings of friendliness, being talkative, and feeling loving under its effects. And MDMA is also known to modify emotion recognition by enhancing detection of positive emotions from eyes, while diminishing sensitivity to negative emotions like fear, sadness, and anger. So when MDMA's prosocial effects are combined with group psychotherapy, the idea is that it would enhance the therapeutic process to influence positive changes in interpersonal traits. Despite all the evidence we do have, we don't currently understand to what extent social improvements occur through changes in these interpersonal traits. And so for this project, I'm interested in understanding whether we can modify these stable traits through MDMA plus group therapy. So my research question is, does MDMA-assisted group therapy facilitate adaptive changes in attachment security and epistemic stance among veterans with PTSD? To address this question, I had two aims. I wanted to examine the changes in attachment anxiety and avoidance, as well as epistemic trust, mistrust, and credulity from before to after 12 weeks of MDMA-assisted group therapy. And I hypothesized that we would observe reductions in avoidance and anxiety, along with increases in epistemic trust and decreases in epistemic mistrust and credulity after the intervention. And then for the third aim, I wanted to quantify the magnitude of change in these traits by looking at effect sizes. Our lab recently finalized the first group MDMA clinical trial, and the results are forthcoming for the primary outcomes. The parent study is a phase 2 open-label single-arm study looking at the feasibility and safety of MDMA-assisted group therapy for PTSD in veterans. And the PI of the study is Dr. Christopher. For the study design, this is kind of dense, so follow along closely with me here. So the therapeutic intervention takes 12 weeks to complete. That includes the preparatory period and treatment period from visit 1 through to visit 15. We administered 2 doses of MDMA, each session lasting a full day. That's at visit 6 and visit 11. The first MDMA dosing session was individual, involving the participant with 2 therapists. And then the second MDMA dosing session was with a group of 5 to 6 participants with a therapy team of 4. The study features a 3-phase model where the first MDMA session is preceded by 4 prep sessions from visit 1 to visit 5. Then both MDMA sessions are followed by 4 integration sessions for a total of 12 therapeutic sessions. During integration, the therapy team helped participants process any experiences that came up during the MDMA session. And for my study, data were gathered for the 2 self-report measures at screening and then study termination at visit 17. And the study termination endpoint here occurred approximately 1 month after the final group integration session. The study sample consisted of 17 veterans diagnosed with PTSD who were on average 42 years old, predominantly male for sex, white, heterosexual, and college educated. Enrolled participants were medically stable without complex psychiatric profiles. In terms of trauma history across the sample, 65% had combat exposure, whereas 35% had experienced military sexual trauma. And on average, participants reported experiencing 4 different kinds of ACEs, adverse childhood experiences. So there were high levels of childhood adversity in the sample. So now the results. These are the results here for changes in attachment anxiety and avoidance. So the spaghetti plots feature changes in these traits over time for each participant from baseline to study termination. The black line in the middle represents the average change across participants. On the plot to the left, we found medium reductions in attachment anxiety after the intervention relative to baseline. On the plot to the right, we found large reductions in levels of attachment avoidance. And you can see that even though participants scored higher on average in anxiety levels than avoidance at baseline, they actually decreased in avoidance to a larger extent. So now we're going to go over the results for changes in epistemic stance. So beginning with epistemic trust, we found a negligible change on average from before to after the intervention. However, you can see some variation in how participants changed over time. 1/3 didn't change, 1/3 went up, and 1/3 went down. So the takeaway here would be that while trust remains stable on average, there's lots of variability in the direction of change for each participant. But most people scored above a 4, which is neutral for the item response, suggesting that most stayed in the range of moderate to higher levels of trust from before to after the intervention. Next, we found medium to large reductions in epistemic mistrust, and here there's a much clearer downtrend for most participants. And then lastly, we identified a negligible change in epistemic credulity after the intervention. However, again here, the average change is not most informative because there was an almost even split in people increasing and decreasing in this trait. And so the different trajectories of change in credulity may be better explained by other factors like baseline characteristics, cohort effects, quality of the MDMA experience, or other aspects of the group therapy components. So further exploration is needed to understand what might account for the differences in trajectories here between participants. To summarize my results, we found large reductions in attachment avoidance, medium reductions in attachment anxiety, and medium to large reductions in mistrust. But contrary to my hypotheses, we did not identify changes in trust and credulity on average, but there was lots of change and difference in the changes in terms of participant trajectories. So for limitations and future directions, our study featured a single arm design. So we're at the pilot phase, so we didn't have a control group. And we had a limited sample size of mostly white middle-aged veterans with PTSD. So our findings may not generalize to other populations. To address these limitations, future studies should replicate these findings in larger and more diverse sample sizes and with a control group. And then since we use self-reports, responses are subject to bias. So future research should use more robust assessments like the adult attachment interview to assess attachment security. And lastly, the traits were measured 1 month after the intervention, so we don't know whether observed changes are temporary or will be sustained in the long term. So future research would benefit from looking at long-term follow-up. Now, what are the clinical implications? So if we think of these traits as transdiagnostic risk and protective factors for psychopathology, there might be a wide array of treatment applications. So first, reliably diminishing epistemic mistrust may enhance treatment response. Given the increased openness to social learning it might stimulate in the group therapeutic relationships, and as a counter to the hypervigilance and negative beliefs associated with PTSD. And then second, our sample had lots of childhood adversity. So this intervention may benefit those with a history of childhood abuse and neglect by diminishing mistrust and possibly modifying internal working models of attachment. And then we also know that childhood adversity is associated with disruptions in social cognition, or this capacity to accurately understand mental states. And so by reducing epistemic mistrust and attachment insecurity, there could be related improvements in social cognitive functioning. And then next, MDMA-assisted group therapy may benefit other psychiatric disorders associated with maladaptive attachment patterns and epistemic mistrust, like social anxiety, borderline, narcissistic, and paranoid personality disorders, which frequently co-occur with PTSD. Then above and beyond symptom reduction, improving these traits may enrich quality of romantic relationships, friendships, and family relations by mitigating interpersonal conflict or social isolation that often exacerbate PTSD symptoms. So I want to thank all the people that made this study possible. I can't go through and name everybody because I'm out of time, but I want to thank my mentor, especially Dr. Christopher, who's been a central guide from start to finish, Nate Diekman for helping with statistical consultation, Stephen and Alexandra Cohen Foundation, and Dr. Bronner Family Foundation for funding our research, Lykos Therapeutics for supplying the MDMA, and then Lars Ryerson Psychedelic Medicine Innovation Fund. And I want to give a massive shout out to Victor Acero, co-founder of the Intercollegiate Psychedelic Network, and my talk coach for this presentation, and for all of his patience and kindness as I worked tirelessly on this presentation. And the rest of and I also want to thank Bianca Watts, director of the Psychedelics Conference, and the rest of the amazing team at IPN for providing this platform for students and early career professionals to share their work. Thank you.